Why AML has been so difficult to treat? We are still using more or less the same chemotherapy as 30 years ago. One reason for that is in part that it's also a kind of heterogeneous disease like many other tumor diseases. But over the last years we have learned a lot. We have characterized the disease better, we are understanding it better, and now this already starts to translate with first targeted therapies coming into the clinic. With regard to new therapies that have become available recently, what you could, for example, label precision medicine, recently there has been an approval for midostaurin, that's a kinase inhibitor for FLT3 mutant AML. Although midostaurin is a very broad kinase inhibitor, we now know that it's inhibiting many more kinases than FLT3 only. And there is also now second generation kinase inhibitors coming up soon. In addition, for mutations in the isocitrate dehydrogenase gene, we now have small molecule inhibitors that already have been approved by the FDA. And there's a new targeted therapy on the horizon. So for the future, we still have to better understand the disease mechanisms, as for example, not all patients that have a FLT3 mutation also respond to a FLT3 inhibitor, because in some of the patients, the mutant clone might not be the driving one, or other mutant genes might impact that deregulated signaling pathway. So we really have to work together to better understand gene-gene interactions, and then perhaps also come up with combination therapies where you combine targeted therapies with conventional chemotherapy, and in the future also hopefully with new immunotherapeutic approaches. The big challenge in the future will of course be to improve trial designs, to test these more individualized patient-centered precision medicine approaches. There is new trial designs out there that are currently being used. What will also be important that we put together large historical cohorts against which these individualized therapies then can be compared. But I think we will have to move away from classical big phase 3 trials before we can prove that, or in order to prove that these new therapies are more effective than the old strategies we have at hand. With regard to precision medicine, it also will be important that we put together the data which we are generating to build up large knowledge databases. Currently we are doing so within the Harmony project, a large private public funded project within the Big Data for Better Outcomes call of the Innovative Medicines Initiative. And these databases will help us to better capture the heterogeneity of the disease, and then also to more easily identify small molecular subgroups that can benefit from these new therapeutic approaches.